Hello and welcome to another episode of the Life After Cardiac Arrest podcast with me, your host, Paul Swindell. Today I'm speaking with Tobias Cronberg, who is a professor and consultant in neurology at Lund University in Sweden. He's a senior investigator on the Targeted Temperature Management 2 trial and also has a special interest in cardiac arrest-induced brain injury. Welcome to the show again, Tobias, and how are you today?
Thank you very much, Paul. I'm very good, thank you.
On the previous episode of the podcast, we talked about the temperature management side of things, or cooling, and also I've spoken with Dr. Keeble previously about things that occur in a cath lab, things that can be done to improve a patient's chances of survival. But today I'd like to talk about one of your specializations, which is prognostication, which, as I understand it, is essentially predicting the future. And as we all know from what's happened this year, we're not very good at it, and it's a very difficult thing to do. Could you just explain what prognostication is?
Yes. When it comes to cardiac arrest, when we are talking about prognostication, we are talking about those patients who remain in coma, who don't wake up after the cardiac arrest, but are in coma in the intensive care unit, and where we are trying to predict what their future outcome would be, whether they will eventually wake up and have a good outcome, or whether their chances of waking up are very, very small, and the chances of a poor outcome, a very severe brain injury or death by brain injury, are very large. So that's what we are trying to prognosticate, the chances of a good outcome.
When patients or families see their loved one go through a cardiac arrest and then get resuscitated, they may think that once a patient has got a ROSC, or their heartbeat has come back and they're essentially alive again, that they think they're possibly going to be okay. But from sort of talking to various people, I know that even if you get to the hospital alive, there still is only a 50-50 chance that you actually come out alive. I don't know if that's true in Sweden as well, but I guess there's a lot of other factors that go into making someone survive, getting to the hospital alive, and also what goes on in the hospital. And I'd just like to sort of think things that a lay person can see and will experience maybe at the scene or have been told by a third party. Can we use those to sort of determine how well someone will do? Like if we saw them collapse, or how soon the CPR was done, how good and how long? You know, are they good predictors of how well a patient would do? Because I quite often see people say, you know, I was down for 5 minutes or 10 minutes, and then someone else will comment saying, I was also down for this time. Are they good comparators? Can we say that two people with the same downtime, will they do the same?
No, we can't say that. Those circumstances around the cardiac arrest, whether it was witnessed or not, whether somebody started CPR immediately or not, and the downtime, those are very important on a group level. But for the individual patients, they are too imprecise to be used for prognostication. So we would frequently see the exceptions, a person with a reasonably short reported downtime who have a very severe brain injury, and a person with a long downtime who has a very small brain injury or no brain injury at all. And that depends partly on the fact that these reports are not very reliable. I mean, at the cardiac arrest, it's chaos. It's a lot of people acting in a hurry, and we won't have very precise estimates of timing. And also the quality of CPR may differ a lot from one situation to the other. So for when I am assessing a patient in the ICU and trying to estimate the amount of brain injury, I would of course look at those circumstances, but I wouldn't use them for any strong advice or decisions around the patient, only to see whether it reasonably fits with the other things I use for diagnosis of brain injury. And I just wanted to say one thing that you were talking about in the beginning, Paul. You said that people may think that just because you're resuscitated, everything will be fine. And it's not like that. We know that, and as you say, approximately 50% of the patients who come to the ICU and who are resuscitated will eventually survive, and the other half will die or have a very poor outcome, at least. And the reason for that is that the brain is much more sensitive to loss of blood flow than the heart is. So the heart may do reasonably well and be restarted, while the brain has suffered irreparable damage during that same time period. And that's the main reason why so many resuscitated patients eventually die.
What percentage of patients will sustain a brain injury after a period of cardiac arrest? And how long does that period have to be to sustain that injury?
Yeah, that's a difficult question to answer. And nobody has the correct answer, actually, because it depends on how you would classify brain injury. What we know is that among the patients who come to the ICU, 50%, roughly 50%, will survive and 50% will die. If you look at comparable countries like the UK and Sweden, that's the rough estimates. And those that die, the majority of those deaths are because of brain injury. So most of the patients dying, they will die due to the brain injury. But then if you look at the survivors and you start doing more sophisticated tests of the survivors, you will find that 50% of the survivors have cognitive problems with their memory or their executive functioning, their ability to plan and perform different activities, etc. And is that because of brain injury? Well, we are not really certain about that. We only know that they have a lot of problems, but it could also be due to other things, such as having hypertension before the cardiac arrest. Because if you look at comparable patients who have a myocardial infarction but no cardiac arrest, they will also have cognitive problems in a similar frequency. So how common is some degree of brain injury after cardiac arrest? We really can't tell at the moment. If you're looking at the whole spectrum, severe brain injury occurs in between 30 and 50% of the patients who come to the ICU.
It's quite a lot, really, isn't it?
Yeah, it's a lot.
Okay, so if someone makes it to the ICU or to the hospital, what do the European Resuscitation Council guidelines say that should be done to prognosticate this person, and who's doing those things?
So we have quite extensive guidelines on this. And the first thing that they state is what should not be done. We should not do too early prognostication. We should not make any decisions around the prognosis during the first 3 days. That's one very important thing. The only exception is if there are strong ethical reasons or if the patient becomes brain dead, because that's something different. But otherwise, in the more standard case, we should not try to estimate the prognosis before at least 3 days has passed. And that's because we need to give the patients a chance just to wake up once we have stopped sedation. Just wait and see what happens with the patient. But during those first 3 days, we should collect information around the extent of brain injury. And for that, we use different methods. And it differs between hospitals which methods would be preferred at any hospital.
And who would be doing those tests? Would you need specialists like yourself, or would they be done by, typically someone's going to be taken into a cardiac type environment. Would it be done by a cardiologist, or do you need a neurologist or some other specialist to do those tests?
At some hospitals, it would be a cardiac intensivist or a neurointensivist, or a general intensivist. At other hospitals, it would be a consulting neurologist like myself doing the tests. It depends from hospital to hospital. The only thing that's really important is that it's a person who is trained to do these tests. But the clinical examination of the patient is not difficult to perform. It's something that every doctor could perform.
And so what are these tests that would be done then? And you said you wouldn't prognosticate to after 3 days, but presumably you'll be doing these tests before then.
Correctly. So we would examine the patient on a daily basis, even when the patient is sedated and artificially ventilated in a ventilator. We would be examining the patient, looking at what we call the cranial nerve functions. And the cranial nerves are the nerves regulating, for example, your pupillary response and your breathing pattern, and whether you can cough or not cough when you are pulling in the tube that you have in your throat. Those kinds of very, very primitive responses, and also testing the level of coma. And we would do that by stimulating the patients, even doing pain response to see whether the alertness of the patient. How deep is the coma? How alert is the patient? It wouldn't be meaningful to test alertness when the patient is deeply sedated, of course, but we would test those cranial nerve responses anyway, and that would give us some information.
What is the difference between, if there is one, being sedated in a coma and just being naturally in a coma?
Yeah, the difference is that anybody with a very healthy brain as well could be in coma if you give them sedatives, and they appear just the same as somebody being in a coma from brain injury. But when we examine these cranial nerve responses, we could see other things in a patient with brain injury, with a severe brain injury, that is, such as the pupillary responses being extinguished, or the axis of the eyes pointing in different directions, telling us that there probably is a structural damage in the brainstem.
What things would families and partners see you doing if they were in the room while you were conducting some of these tests? I mean, I've seen doctors where they shine a torch in the eyes, but I'm sure it's moved on from just shining a torch in the eyes. But and pinching people, is that the sort of things that you'd do?
Yeah, that's actually the sort of things that we do. But I always start by looking at the patient, to look at whether the patient has any involuntary movements. Because if they have twitching or shaking, it could be a sign of myoclonus, which is a severe sign, unfortunately. And so that's a sign of a poor or a worse prognosis. You may survive anyhow. Some patients do, but most patients with myoclonus will not survive because they have such a severe brain injury. That would be the first thing that I do. And then I would be checking the ventilator to see whether they are triggering the ventilator themselves and starting the breathing themselves and just being helped by the ventilator, or whether the ventilator is doing all of the job. Then I would move on to talking to the patient, just to checking whether there is a response. I would talk to the patient when the patient is lying there with the eyelids closed, and I would, after that, open the eyelids and talk to the patient to see whether they can somehow orient towards me, somehow doing something on command. And that is a patient, of course, that's not deeply sedated. I would ask them to open and close their eyes, look at me, look to the other side, etc. Maybe move a hand or something like that. And sometimes they respond, but if they are unconscious, of course, there will be no response. And then I would do these things that you say, shining a torch in the eye, touching the cornea of the eye to see whether they blink, if they have a blink response. I would pull in the ventilated tube to see whether they cough. and I would suction down into the throat to see whether they have a response to that. Those are reflex responses. I would move the limbs of the patient to see if they are relaxed or if they have an increased tonus of their muscles, which also is a sign of injury. And I would test their stretch response, the stretch reflexes in the limbs with my little hammer. I would also see if they have this plantar response where you pull a stick under the foot to see whether your big toe is pointing upwards or downwards, where an upward response is something bad and a downward response is the natural thing. And then I would move on to the painful stimuli to see whether I can arouse the patient by pressing. I would press on the mandibular joint, and I could also rub on the sternum with my hand. Those are uncomfortable things. So if I would do it on you when you are awake, you would probably say "I," and you would think that that was uncomfortable. And for somebody in coma, they may be aroused by that, and they may be aroused to different levels, and that would be quite predictive. If they suddenly take their hands up to my hand and try to push it away, it's a very, very good sign if I could elicit that kind of response.
And I understand that there's some scales that you might measure people against, the Glasgow Coma scale and the full outline of Unresponsiveness Scale.
Yeah.
Could you just tell me about those a little bit?
Those are scales that incorporate these different things that I was talking about. The response of the patient, the response to verbal stimuli, if you talk about the Glasgow Coma scale, and also the response to painful stimuli. And in the 4 score is slightly more advanced than the Glasgow Coma scale. So it's getting more and more popular these days, the 4 score, because it also has this pupillary response and corneal response, and it takes into account whether the patient breathes against the ventilator or not. And it doesn't have any verbal response in the scale, which the Glasgow Coma scale has, because these patients are intubated, so they can't speak. And that's a development in the 4 score.
I'm guessing that these are sort of just general for anyone in a coma. Are there anything particular to cardiac arrest survivors that these scales either do or don't allow for?
No, I wouldn't say so. What is particularly important in cardiac arrest is the pupillary responses and the corneal responses, because those are the most robust reflexes. If you don't have any pupillary responses, for instance, at 72 hours after your cardiac arrest, and you're not affected by sedation, then your chances of survival is very bad. So that's one of the most evaluated reflexes that we have. The corneal reflexes are similar. And then we have the response to painful stimuli, which has been very much investigated and very much used. So if you don't have any response, or if you just stretch your limbs as a general reflex when you do this stimuli, the whole body stretches out, then that's also a very bad sign. But it's not as reliable as the pupillary response. It used to be a central part of the examination, and people tended to withdraw intensive care for patients who didn't have any motoric response to pain. But that's not the case today, because it's not reliable enough. We need other investigations and other signs of brain injury to make any decisions.
I've got 2 sort of questions coming off from that, which should be, a lot of these tests are done while patient is in a coma. What happens if a patient comes to you and they possibly aren't put into an induced coma, or they're sort of in and out of consciousness? Would you do any tests on them? And what about patients that perhaps don't even go to ICU?
Yeah, There could be two reasons for not going to the ICU. One reason could be that you had a very short cardiac arrest. So when you come to the emergency room, you're already awake, and that's a very good sign. So for those patients, we normally don't need to do any prognostication. We could only say that this will be a good outcome when it comes to brain injury. The other reason for not going to the ICU may be that your prognosis is so poor, you're in such a bad shape that they wouldn't take you to the ICU. And of course, those patients wouldn't survive for very long, and I wouldn't typically see those as a neurologist. Wouldn't be much prognostication done. So the typical patient that we do prognostication with is in the ICU. And if the patient wakes up before the time point of more formal prognostication, which we do, as I said, at least 3 days after the cardiac arrest, and often it's four days after cardiac arrest. Of course, some patients wake up before that, and they still have a pretty advanced brain injury. That may happen. But on the other hand, if the patient wakes up and can be extubated, taking the ventilator away, then there's no reason to do any advanced prognostication at that time point, because the reason for prognostication as it is today is mainly to be able to make a decision whether to continue intensive care or not.
Does the time that someone is in a coma or sedated indicate the likelihood of the outcome?
Yeah, it does. So we do know that for patients who do not wake up, the chance of awakening will be smaller with each day from the cardiac arrest, starting on day 3 and then moving onwards, because until day 3, for the first 2 days at least, patients will be sedated, so you can't estimate for those days. But after that, they are expected to wake up, and if they don't wake up, the chances of awakening and good outcome are getting smaller by the day. But it does not exclude awakening with a good outcome. So we can't just judge from the fact that the patient hasn't awoken, but the chances of ever awakening are getting smaller. But there may be also pharmacological reasons for not waking up, such as the patient may have respiratory problems so that they need a ventilator, and then they will have some sedation to tolerate the ventilator, and then of course they won't wake up. Or they may have a lot of epileptic activity in the brain, and we need to give them a lot of anti-epileptic medication, and that may also keep them sedated.
You talked about almost as if there's a level of confidence in some of the tests. Could you sort of go through what they are? And I understand that you use the test as a whole rather than individually.
That's correct. We always, before making a statement on prognosis, we'd like to have information from several different sources. So we do the clinical examination of the patient to see how they respond. We do something called EEG, or electroencephalography, and that's where you put electrodes on the skull that record the electric activity of the brain. And that's very useful to see what kind of what level of activity you have in your brain. And if you have a pathological activity, that may be a sign of a severe brain injury. And it has been a lot of research done on the different kinds of EEG patterns of the cardiac arrest and the timing of these patterns. So that's one part of the calculation or of the whole estimation. That's also the function of the brain, just like the clinical examination. And then we have another electrophysiological examination called somatosensory evoked potentials. And that's an examination where we stimulate a nerve in the handle of the patient, down by the hand, And then that signal travels all the way up to the brain, and we can record the signal from the brain similar to the EEG. And if those responses are present, it doesn't tell us very much, because they may be present also with a severe brain injury. But if they are absent, it's a sign of a very severe injury, and it's a very reliable sign. And then, of course, we want to do imaging. So typically these patients would have a CT scan, computed tomography scan of the brain. Like anybody who have a severe head trauma and comes to the hospital, you do a CT scan of the brain. And we'd also do it after cardiac arrest. The problem is that the injury after cardiac arrest is very diffuse. It's in all of the brain, and therefore it may be difficult to detect on a usual CT scan. It's better to do an MRI scan. It would give us more information. And in the more complicated cases, we would typically do an MRI a bit later. But CT scan is often done early to exclude any bleedings in the brain or any traumatic damage. And if you see that the brain is swollen, the whole brain swollen on the CT scan, it's a very bad sign. And then we can also measure in the blood substances, small proteins that comes from the nerve cells and that are released from the brain into the bloodstream. And this, in particular, one substance called neuron-specific enolase. So it's neuron-specific, meaning that it comes from the nervous cells, the neural cells. And it could be measured at 24, 48, and 72 hours after the cardiac arrest. And if we have a severe brain injury, we would typically have high levels of this neuron-specific enolase. So if I see a patient who have a swollen brain on the CT, who have no responses when I examine, and perhaps not even any pupillary responses when I shine my torch into the eye, who has a very severe pattern on the EEG, and who has no responses when we do the stimulation, this SSAP stimulation at the hand of the patient, then I would be able to conclude that we have a very severe brain injury. And I would be very comfortable concluding that. But in many cases, it won't be that uncomplicated. It would be more complicated, saying that the EEG looks bad, but on the other hand, the levels of this neuron-specific enolase are not very high, and maybe it was a short time to ROSC, to short downtime for the patient. And then we want to delay, and we would treat some more. We would perhaps do an MRI to get more information, and it would be more prolonged.
There's a couple of things I would like to just go back over. You just mentioned MRI, so I'll go back to that one first. Are there any sort of common patterns that you would see with someone who's had a cardiac arrest in terms of the progression of hypoxia? Does it affect particular parts of the brain in a sequential order or in a common order?
No, I would say no. There are vulnerable areas. So the whole cortex of the brain is vulnerable, and also a cortical structure called the hippocampus, which is very important for our memory and which is in the middle of the temporal lobe. It's also very vulnerable. The small brain, the cerebellum, your small brain, which is in the back part of your skull, is also very vulnerable to this injury. And also some deeper structures called the basal ganglia. And in one patient, it may be the cortex that is more affected. In another patient, it may be the basal ganglia that are more affected. And it also depends on the timing of the MRI, because the damage tends to evolve over days during the first week. So it depends. If you do it very early, it may be more the basal ganglia. A bit later, you would see more of the cortical damage. And you would rarely repeat the MRI in one individual patient, because doing an MRI is quite complicated with a patient who is in a ventilator.
Yes, I can imagine that. And with cooling and all of the other paraphernalia.
Exactly. And what is typical with these patients that we don't see is that we don't see damage in the brain stem. So the brain stem, which are the oldest parts of our brain from an evolutionary standpoint, they are more resistant to brain injury from cardiac arrest. And that's where the central functions like your brainstem reflexes, your respiration, and your alertness is oriented. It's within the brainstem.
It's very interesting. I'm sure we could go into it for hours about various parts of the brain and how they are affected and what common sequelae that patients experience afterwards, things like memory and fatigue. But that wasn't the topic of today's podcast. But the other thing...
Well, actually, I may interrupt you here, but there is one thing that's central about this, because since the brainstem is so resistant to cardiac arrest-induced injury, you may very well survive with just your brainstem and not the cortex. And that's what we fear the most. That's which was used to be called the vegetative syndrome. And we try to avoid that name now. We call it the wakeful unresponsiveness syndrome. So you look awake, but you're unresponsive because you don't have any consciousness. So you have a patient without any consciousness who looks awake, who is able to breathe, who open and closes the eyes, may even follow a bit with the eyes, but who have no consciousness and is completely dependent on others for support and artificial nutrition, of course. If you give nutrition to such a patient, they could survive for many years in a nursing home, and it's a very tragic condition. And it's a common condition in countries where intensive care is always prolonged for cardiac arrest patients. And it's very uncommon in countries like Britain or Sweden, where we withdraw intensive care if the prognosis is very poor.
I mean, that is a whole subject in its own right. I guess, I mean, I did have one question about the timing of EEGs, but perhaps we can come back to the withdrawing of life-sustaining therapies. But just on the timing of EEGs, you mentioned that you do it at certain periods and you can see certain things at certain times. If a patient's in and out of consciousness, if you're doing some of these things at certain times, is there a chance that you could miss someone coming out of their coma, or do they do EEGs constantly?
Yeah, we do constant EEG monitoring, but not many centers do that. And you do get some prognostic information just by looking at the evolution of the EEG. But if the patient is going in and out of coma, the staff will notice just from how the patient behaves. Because if you are becoming awake, you won't tolerate having a tube in your throat. You will start coughing and resisting and trying to pull out your tube.
If we sort of go on to the withdrawal of life-sustaining therapies, but just before that, I'd like to say one question that was suggested to me is about the sort of a whole prognostication thing is, why are many families told to expect the worst or given a pessimistic outlook by doctors? You know, are we clinicians and society not very good at predicting what's going to happen, so we err on the side of caution? Or is just the stats say that more people are likely to die than survive?
Well, I think the doctors in the ICU around these patients are very used to having bad outcomes. And it is important that the relatives are prepared for that, of course. So there is a point in giving early information that it doesn't look really good, so that the relatives have the possibility to go home and prepare themselves. I don't like to have a talk about the prognosis like 4 days after the cardiac arrest and deliver all the information, and also telling that we are discussing to withdraw intensive care because that's the usual situation at that time point, to a family that's not prepared at all. And typically, we do collect a lot of information. We have these, as I told you, these blood samples of neuron-specific enolase. We have some, perhaps there's been an early CT showing generalized swelling. Perhaps the patient has myoclonus, these muscle twitching that is informs us that there is a poor prognosis. I think, hopefully, the bedside doctors, the ICU doctors, would be more pessimistic in those patients having early signs of poor prognosis than the ones who don't have such signs.
Mm-hmm. And in countries where they don't practice withdrawal of life-supporting therapies, what do they find? What do they see? Do people ever wake up after 6 months, 9 months, a year or longer?
Very rarely. Of course it happens, and there is an evolution. So patients who from the beginning have this complete unresponsive syndrome may become slightly responsive later on. So they become a little bit better, so to speak, that they may at times have some kind of response to their environment. Maybe squeeze a hand or open eyes or something like that, but they don't become able to communicate. There are some rare cases with patients who evolved to become awake and able to communicate also. So most patients who after 1 week has not awoken, they will not wake up later on. And if you look at the outcome of cardiac arrest in a country like Italy or Korea, where they don't withdraw intensive care because of their tradition, you could see that more than half of the survivors of cardiac arrest have a very severe brain injury. And most of those patients will be in this very, very poor state where they are completely bedridden, and at the nursing home, they need somebody else to take care of them all the time. And they have a very, very limited, if any, ability to communicate.
Yes, I guess it's a very difficult decision to actually make, whether someone's life is how they would want to be like that, or whether, if they can't communicate unless they've actually previously indicated how they would want to end their life if they're in that situation. I imagine it's very difficult deciding that for them, whether it's a medical decision or a family decision.
Yeah, and that differs from country to country. What is your legislation and what is your tradition? What is the role of the family in your country or in my country or in another country? That differs a lot. So in Sweden, for instance, the doctors and the staff will make the decision, and we would make a consensus decision. So no physician can make this decision alone. It has to be in consensus. But we will make the decision and we will inform the relatives. But we will also have a discussion with the relatives where we try to seek some kind of consensus. So we don't like to push. If the relatives resist and say that, well, we are not comfortable with this decision, we tend to wait and we tend to postpone like 24 hours or something like that. But we make the decision, so we don't put it. We feel that we can't put it on the shoulders of the relatives to make this decision. It wouldn't be right, because in reality, it's the patient's decision to make. It's nobody else. And if the patient can't make a decision, the relatives can't be surrogates to make the decision for the patient. In Sweden, they don't have that position. So we are asking the relatives, what do you think that your husband or wife or grandfather would have wanted in this situation? What would his or her opinion have been? And typically in Sweden, the relatives would say he would never accept to have a severe brain injury when he awoke. And he has been talking about this, so we have been talking about this, and they wouldn't accept.
Does the concept of organ donation come to complicate the situation? I mean, in England, I think it's just come in by law that you have to opt out now, otherwise you're in the donation program. So does that complicate things? Did it add extra pressure from external sources?
Yeah, it does. It hasn't done it in Sweden very much because, as I told you, very few patients become brain dead, what we call neurological dead, when the brain stops functioning. If you're brain dead, then you could have an organ donation in Sweden and in all other countries as well. But most of the cardiac arrest patients, they will have some function in the brainstem and they won't be brain dead. But now we have this new concept of donation after circulatory death, which you have in Britain since a few years back. And that's something different. If the doctors say that you have a severe brain injury and your prognosis is certainly poor, then we can stop intensive care. And if your heart stops, then you could become an organ donor at that situation. And cardiac arrest patients are organ donors in Britain after circulatory death. And we don't have a lot of reports on how many or how common or how it is done. I couldn't tell you more about it, and I don't have any personal experience, but it's certainly possible. And it does complicate things, of course.
Of course, yes.
It could be something good, I think. It could. I mean, because if you have a cardiac arrest and, you become dead, and then you're resuscitated back to life, and then you're brought to the hospital, and then it turns out that you have such a bad brain injury that you can't be saved, then at least it was good for somebody else who got the organs and who could have a continued life. And it could be some comfort for the relatives. We know that from other organ donor situations.
When we talked about the cooling the other episode, you talked about how the fact that patients who got cooling, we don't still know whether it is good or not, but you said it brought a whole host of extra benefits to cardiac arrest patients in that they came to the ICU, had a lot more treatments, and they were looked at perhaps a little more closely. Could that be the same in this situation, that if we do routinely use patients who have had a cardiac arrest and are not going to survive, that perhaps they will look at the actual determining factors for whether someone is in this state that you just talked about or not? Can we see more tests? And how good are we actually at predicting the outcomes of patients?
Yeah, that's a very important issue. It's really the focus of most of my research is to improve the methods for prognostication, and we are not very good currently. We recently did an evaluation of the European guidelines for prognostication, and these guidelines states that you need information from several sources to be certain, and there is an algorithm that you would follow where you have all these different methods incorporated. And we tested in a very large group of patients how good the algorithm was. And the specificity of the algorithm, the ability of this algorithm to say certainly that you would have a poor outcome, that was very good. So it's very safe. It did not identify any patients who did not ultimately have a poor outcome. But on the other hand, the sensitivity, the capacity to detect patients with a poor outcome was not very good, only 40% approximately. So many patients will be in the gray zone. Also, when we have done the EEG and CT scan and neurological examination, we will still be uncertain in a large fraction of patients. What we would typically do is to wait another day or maybe 2 days. And if the patient doesn't wake up, many physicians would just decide to withdraw intensive care. in those patients. And that wouldn't be very safe, I would say. So we still need to improve these methods a lot. And there are a lot of new methods coming up and a lot of improvements coming up. And I think also the fact that organ donation is becoming more common will improve the diagnostics. It will be more focus on having very safe methods to be able to predict.
I do hope so, as obviously there's going to, well, in England anyway, there's going to be more people who are organ donating, and we really want to be sure that they are in the right state to be able to do so, don't we, as a society in general?
Yeah, it's very important for the trust in the society to know that everything is done with very safe methods and no mistakes. If there suddenly would be mistakes in this area, people would lose trust in organ donation. They wouldn't dare to become voluntary organ donors or having those cards or registers if they didn't trust the system.
So if a country practices withdrawing of life-sustaining therapies after however number of weeks, what's the sort of minimum that we might see in a European country like Sweden or Britain on that?
Typically, withdrawal of care would occur on day 4 or day 5 after the cardiac arrest.
But what's the longest that you've seen? Because I've seen in the group that patients say they were in a coma for the majority of patients in a coma are generally a very short time, from a few days maybe up to a week. But I've seen other people who have been in a coma for several weeks, even up to a month. I think there was one person.
It happens. It's not common, but that may be a patient who are kept sedated for a reason. As I told you, for example, for respiratory reasons. If it's the brain injury that causes the coma, it's very uncommon that you stay comatose for 3 to 4 weeks. But maybe you have, for example, epileptic activity in your brain, so that you will be sedated for that reason as well. And of course, we have those outliers who are comatose for 3 or 4 weeks, but it's not many percent of all the patients in the ICU with cardiac arrest.
So where withdrawal of life-saving therapies is routinely practiced, I've read that generally we don't have that many people with a severe brain injury, and most of us are classed as having a good outcome. I've seen I've quoted before on this podcast, the cerebral performance category, where 1 or 2. Would that be true? And what does that 1 or 2 mean, and what is good?
Yeah, so a good outcome is considered a cerebral performance category 1 or 2. And in category 1, you may have some minimal neurological problems, some minimal brain injury, but you should be able to return to work, to your regular work. And if you have a category 2, you have a moderate brain injury, and you should be able to work in a sheltered environment. So you could have a adjusted work situation, adjusted due to your problems with, for example, memory or attention, or you have a lot of fatigue and you have difficulties performing certain tasks. That would still be considered a good outcome, although you have a lot of problems, of course. But you are able to take care of your daily activities. So you could eat and you could dress yourself and you could go to the bathroom and you could even travel around in the community by yourself. But if you are on the other side, if you have a poor outcome, then you have category 3, CPC 3, cerebral performance category 3. That's a severe brain injury. And a patient in a CPC 3 is somebody who needs somebody else to take care of them on a daily basis for their daily activities. Often they would still be up and walking because you don't have a lot of problems with your motor functions. You may have some twitching still or some slight coordination problems, but typically you would be up and walking, but you would have a lot of memory problems, a lot of personality change, So you wouldn't be the same person, and you wouldn't be able to do any kind of work. You would need a personal assistant during daytime or a nursing home. That would basically be the alternatives. And the CPC4 is this chronic vegetative or unconscious wakefulness syndrome, this vegetative state, where you are just lying in the bed and you're not able to communicate with anybody. And if we look at countries where they don't withdraw life-sustaining therapy, most of those with a poor outcome are actually in the CPC4 category, and there are not so many with the up and walking severe brain injury type of situation.
What about the patients who have a 1 or 2 are classed as good, but as you mentioned, they quite often may have additional problems? They may go on unaddressed. How can we resolve that? Is the tag of having a good outcome not very helpful in these cases? Because, you may have memory problems, you may have fatigue problems, you may be emotionally changed or personality. I've seen it in lots and lots of cases, but we're still classed as a good. Is the CPC scale fit for purpose in cases like us?
Well, I think it's fit if we are relating it to prognostication in the ICU, where we are deciding whether to prolong intensive care or simply stop intensive care and letting the patient die. I think it's very fit to discuss in terms of good and poor outcome, but that does not exclude that those with a good outcome will have a lot of problems that we need to deal with. Of course, we need to deal with these problems, but we also know from large investigations that their quality of life is good. So if you have a good outcome after cardiac arrest, if you survive cardiac arrest in a country like Britain, you will very probably consider your quality of life being good afterwards, if we ask you. And that's the most important thing, I think, that you have a good quality of life. But you have a lot of problems, and we know that these problems are not captured in the usual follow-up after cardiac arrest, only in places where they have organized also a neurological follow-up of the brain injury problems. They will capture these patients. Otherwise, you will have a follow-up with your cardiologist, and he will be looking at your heart and be very happy about your heart, but not really be able to look at your brain injury problems.
And we don't really, as you say, have any sort of robust guidelines about that at the moment?
No, we're just in the developing phase for that. In the last part of the European guidelines, 2015, there were some advice on follow-up. And in this new guidelines, which was supposed to be out this year, but will be postponed to next year, there will be more extensive guidelines on follow-up of cognitive problems after cardiac arrest. So it is developing, and in the future, I'm sure that this will be a natural part, that we combine the neurological and the cardiological follow-up of cardiac arrest patients.
Well, that's good to hear, so that we can capture some of those problems that people go on with their memory and fatigue and what have you, whether there's anything you can do about them directly, or whether it's just a case of having interventions so that people learn how to manage it, or to even learn why it's been caused. I quite often see people who perhaps put down some of the symptoms that they've experienced down to just medications and things like that. Perhaps some of them are, but I guess we don't know 100%.
One thing that I often notice when I meet patients after cardiac arrest is that they are worried that they got dementia, and just by assuring them that this is not dementia, this is due to your cardiac arrest, and it won't get worse. It will gradually get better because you will adjust and you will find ways to go around it. That's I think just assuring them that is helpful, because they are so worried that they are becoming demented.
that thought has crossed my mind.
Yeah.
And also it's a totally different subject, but does it put you more likely to get dementia when you're older?
No, not as we know at least. But I have to say, I don't think there has not been any studies on that.
So I think we're probably coming to the end of my questions on this. So do you think you could just sort of sum up where we are with prognostication, and just to sort of put lay people in the picture, and also where perhaps you think we may be going with it, what tools that you may see that we have in the next 5 or 10 years?
Yes, to try to make it brief, I would say that brain injury after cardiac arrest is very, very usual for patients who are treated in the ICU after resuscitation, and approximately half of the patients will die. Most of these patients will die after a decision to withdraw intensive care because we have diagnosed a very severe brain injury that is not compatible with a good outcome. And we have different methods to look at the brain and to diagnose this brain injury. And these methods are very much in development, and we have new blood samples, new ways to look at the EEG, and new imaging methods coming up, which will make it even better. But already the methods that we have today are very safe, and the guidelines that we have are very safe. So when we are sure that the prognosis is poor, it is reliably poor. Yes, I think I would frame it that way. I would also like to say that these decisions are necessary to make, because if we don't make them, if we would just be reluctant to make decisions to withdraw intensive care, we would face a situation where very many patients, a very large fraction of the patient, survive with very severe brain injury in nursing homes. And that's a very tragic outcome of cardiac arrest that most of us certainly want to avoid.
Indeed. Yes, thank you for summing it up like that. It sort of puts it very clear on this sort of very difficult and sensitive subject, really. I guess it's very difficult for you guys doing that, making those decisions day in, day out, and dealing with the relatives or families where you have to withdraw therapies. But when patients come through it and they're back into a normal life again, it must be very rewarding for you. Yes,
it is. It is indeed. But I also think that these situations where we have a tragic outcome, where the outcome is poor, still meeting the relatives and discussing with the relatives around the evidence and all the different methods that we have used, I think it's also rewarding, because it's relatives who are struggling with a difficult situation, and we are making very difficult decisions. But on the other hand, it's very, very important discussions. And for me, it's rewarding to be able to be there and to share their agony and to try to give comfort anyhow. And some of the things we could always comfort them is that for this loved one who have a severe brain injury, they have not suffered. There is no suffering involved in it. And when we decide to stop the intensive care, it will be very calm, it will be very peaceful. It will not be a situation of pain or struggling. So in that sense, it's a good way of dying.
I think that's a great way to end this episode. So thank you very much again for your time, Tobias, and I'll hopefully speak to you again soon. Thank you.
Thank you, Paul.
This concludes this episode of the Life After Cardiac Arrest podcast, and I'd love to know what you think. And you can do that via Facebook, Twitter, Instagram, or the website southerncardiacarrestuk.org. And you can find us by Googling Southern Cardiac Arrest UK or the Life After Cardiac Arrest podcast. If you have found value in this or other episodes, please help spread the word by leaving a review on your podcast provider, such as Apple, or wherever is convenient. And don't forget, if you want to know more about life after cardiac arrest, check out our books Life After Cardiac Arrest on Amazon. Make sure you click subscribe, and I'll speak to you next time.